Well, good morning, everyone. I'm Jennifer Walsh. I'm a Senior Media Officer with the Institute of Medicine and National Research Council. I want to welcome you all for joining us this morning, those of you who are in the room with us and those of you who are joining via the web. Again, this is a discussion to talk about the new report that was just released at 11 a.m. Eastern Time, Sports-Related Concussions in Youth, Improving the Science, Changing the Culture. The report is now available and it can be downloaded as a free PDF along with other related materials at www.iom.edu. This will be a 1-hour briefing unless we run out of questions beforehand. We will start off with some opening remarks to introduce the study and give an overview of the report's findings and recommendations, and then we will open up the floor to questions, both those of you in the room and on the web. Those of you in the room are asked to go to the microphones on either side of the room to ask your question. And those of you on the web, if you can type in a question in the Q&A text box and click the submission button located under the player. We ask anyone who asks a question, if you can please identify yourself and your organization before asking that question. And with that, let me introduce Clyde Bainey, the interim Leonard D. Schaefer, Executive Officer of the Institute of Medicine.
Good morning. Welcome to the public release of the Institute of Medicine and National Research Council report, Sports-Related Concussions in Youth, Improving the Science, Changing the Culture. Despite the increased attention to and proliferation of research on sports-related concussions in recent years, there continues to be confusion and controversy in several areas, such as the effects of multiple concussions on the vulnerability of youth athletes to future injuries, when it is safe for a youth athlete to return to sports and to school following a concussion, and the effectiveness of protective devices and other interventions in reducing the incidence and severity of concussions in youth athletes. Against this backdrop, in October 2012, the Institute of Medicine and the National Research Council convened the Committee on Sports-Related Concussions in Youth to review the science on sports-related concussions in youth from elementary school through young adulthood, including in military personnel and their dependents. The committee's report, being released today, explores the causes and consequences of concussions in youth, their treatment and management, and the effectiveness of protective equipment and other interventions for the prevention of injury. I'd like to recognize the important contributions of the staff for this project. Morgan Ford was the study director, was assisted by Carol Spicer, Wendy Keenan, and Samantha Robotham. The study was done under the auspices of the Board on Children, Youth, and Families, directed by Kimber Bogard. The authoring committee is represented today in order of their appearance by Bob Graham, who's the chair, Tracy Covison, Susan Margulies, Arthur Marylander, Fred Rivera, who's the vice chair, and Christy Arbogast. Bob Graham is director of the National Program Office, Aligning Forces for Quality at the George Washington University. Tracy Covison is an associate professor of kinesiology and the undergraduate athletic program director at Michigan State University. Susan Margulies is George H. Stevenson Professor in Bioengineering at the University of Pennsylvania. Arthur Marylander is Director of Pediatric Neuropsychological Services and an Assistant Professor in the Department of Psychiatry at Dartmouth College. Fred Rivera is the Seattle Children's Guild Endowed Chair in Pediatrics at the University of Washington School of Medicine. Christy Arbogast is the Engineering Corps Director at the Center for Injury Research and Prevention at Children's Hospital of Philadelphia and is an Associate Professor of Pediatrics at the University of Pennsylvania. Dr. Graham will begin with a brief overview of the committee's statement of task and how they approached that task. Each of the other representatives will then take turns presenting the committee's findings, conclusions, and recommendations. At that point, the panel will be available for questions, both from the audience and from the web, And I'm very pleased to now turn the program over to Dr. Graham.
Thank you, Clyde, and good morning. It's a pleasure to see you all here, and those of you who are with us virtually. As Clyde said, I'm Bob Graham. I have served as the chair of the committee for the past year. It's been a privilege working with them. Clyde did a very good job of introducing individuals on the committee who are here. There are two additional committee members who are here, and I would at least like to recognize their presence, Drs. Joseph Wright and Neha Rakur. And there are, hopefully, the rest of the committee is watching this and see whether or not we live up to their expectations. Clyde was also very gracious in recognizing the staff that we worked with, and I think Fred and I, as chairs, would echo our appreciation for their work and support. Studies of this type usually take about 18 months, and this was done inside of about 9 months. A lot of work for the committee, an awful lot of work for the staff, and we're very appreciative of what they did and the way they brought things together. So with that, my job is to start out, give you just basic background, and then we'll go to the 5 presentations that go into the substance of the report. We'll come back. I'll comment on our 6th recommendation. Thank you. There are only 6 recommendations, so we try to keep it simple and keep it focused. And then we'll open it up for Q&A. Mike's on either side of the room. I will serve as moderator, take people roughly in the order that they come, but we'll try to make sure as we get questions from the web that we get them feathered in and everybody has a chance. First slide shows the project sponsors. Very important, the IOM has very limited funds to conduct the type of research and studies that it does. We're very dependent upon sponsors who will support the areas of interest and priority. The sponsors also have the opportunity to look at the statement of tasks, give comments, make sure that we are doing something that focuses on what they see as the most important issues, because frequently the report comes back to the sponsors and says, we've looked at it, and this is what it's important for you to do. And you'll see that coming up in our recommendations. Second slide gives you the specific statement of task. I will not read that, and I know it is visible for those of you on the web also. You can see, essentially, we had 2 things to do. One is to assess the literature, and we limited ourselves to the world literature, but in English language, and focused on children from the age of 5 to young adults to the age of 21. This was a conscious decision on the part of the committee to set boundaries. Children at the age of 5, roughly when they start schooling. 21, roughly at the time that they finish college. There can be legitimate issues in terms of brain development and the impact of sports outside of those boundaries, but that was our focus. And then our responsibility, having done all of that research, conversations within the committee, what are the significant findings? We make recommendations. Committee's approach, pretty much just have covered. A question that we always have as we start this discussion is, well, what is your definition of concussion? So I think the next slide will give you that definition. Concussion is a brain injury along a spectrum of mild to moderate to severe brain injury. Concussion is in the mild section. Next slide. Whoops. Okay, that's, I'm sorry, Morgan, I thought the definition was going to be on the slide, but I think it must not be. If you would go back, I will read the definition that those of you who are familiar with this field, it is derived from the 4th International Conference on Concussion held in Zurich in 2012, and states in part, concussion is a brain injury and is defined as a complex pathophysiologic process affecting the brain, including induced by biomechanical processes. So that is the definition which provided the floor for our activity. So now we can go to epidemiology, and I think Tracy, the panel will speak from their places.
The committee found that over the past 10 years, there has been an increase in the number of reported concussions, and this could possibly be due to an increase in awareness or reporting of concussions by athletes. However, we do not know the true incidence of concussion, as several concussions go unreported, as well as the lack of consistency in terminology with different studies that have reported different definitions of concussion, as well as different athlete exposures that were used in those studies. The committee found that the majority of research on the epidemiology of concussions is at the high school and the collegiate level, with very little to no data that has been reported younger than the high school level, as well as on club sports and competitive and recreational sport settings that are outside of the academic setting. The committee found that recently there has been a shift in the incidence of concussions, where there are more concussions reported at the high school level compared to the collegiate level, specifically in sports of football, men's lacrosse, soccer, and baseball. When we looked at differences in trends for the incidence of concussions, we found that there is a higher incidence of concussion in competition compared to practice, except for cheerleaders who have a higher incidence in practice compared to competition. Concussion rates have been found to be higher in female athletes in comparable sports to males. Therefore, female athletes in soccer, basketball, ice hockey, softball, and baseball have a higher incidence of concussion compared to male athletes. We have found that there are certain sports that have a higher risk. This slide is in no particular order of sports that have the highest risk, and the majority of the literature comes from high school and collegiate athletes. For male sports, the committee found that the higher incidence of concussion have been found in ice hockey, football, lacrosse, wrestling, and soccer, while female athletes have a higher risk of concussion in soccer, lacrosse, basketball, and ice hockey. The committee found that when we looked at the incidence of concussion, there is no consistency and there's pretty much no data that is collected on race or ethnicity. And if potentially there are differences in race and ethnicity, it could be possibly attributed to social economic status, to cultural or psychosocial differences, to education or lack of health care. The committee found that there is no published data on the incidence of reported concussions during basic training for military recruits. In 2012, there was approximately 26,000 concussions, or MTBIs, reported in military personnel worldwide. Out of these 26,000 concussions, or MTBIs, it represented 85% of all TBIs in military population. In addition, more than 80% of TBIs in military do not result due to deployment settings. The majority of concussions or TBIs in military personnel are due to motor vehicle accidents, falls, sport and recreational activities, and military training. Therefore, the committee's first recommendation is the CDC should establish and oversee a national surveillance system to accurately determine the incidence of sport-related concussion in individuals aged 5 to 21. The surveillance system should include demographic information such as age, sex, race, and ethnicity, pre-existing conditions such as learning disabilities and ADHD, individuals who have a previous history of concussion and the time that their concussions occurred, as well as the use of protective equipment and impact monitoring devices. And finally, surveillance systems should also include the qualifications of personnel making the diagnosis of a concussion.
Thank you. Susan?
The committee was charged to review triggers and thresholds for concussion in youth and found a rich literature about how the brain grows and changes in that large age range between ages 5 and 21. But the committee found very little evidence that addresses how this normal development timeline may actually make the brain more adaptable or more vulnerable to a concussion at different ages. The committee found available biomechanics evidence was mostly from adults and mostly in more severe traumatic brain injuries, not concussion. Regardless, the animal studies revealed that linear and rotational head movements are important biomechanical triggers, and that injury thresholds for more severe traumatic brain injuries with a loss of concussion depend on the direction that the head is moving and also the age of the individual. And finally, if there was a previous traumatic brain injury. The animal studies showed that the spacing between the repeated traumatic brain injuries influenced the responses. After a careful review of the evidence, the committee found very limited information about biomechanical triggers and thresholds for concussions in youth. But the limited evidence we did find shows that the thresholds are going to vary with age. The committee found no scientific evidence about thresholds for the number of head impacts or the number of concussions that might be tolerable. Thresholds for concussion are an important missing piece to understanding how concussions may occur in children. And on the next slide, I'll show you that what those thresholds are used for is to create a risk curve. So a threshold might be a level of acceleration in a particular direction. That would be the biomechanical parameter on the horizontal axis that you see. But on the vertical axis, you see the chance that a concussion would occur. So that would imply, as you're looking at this, that it's not an all or none. If you exceed a threshold, there's an increasing chance that you'll get a head injury, but not a 100% chance that you'll have a head injury. And that's a very important point. How do we determine what risk, if you experience a certain level of acceleration, you would have or a child would have for concussion? Scientists use surveillance data with monitoring equipment. Is very important to say, under these types of conditions, what fraction of children at what age, under what conditions, would experience a concussion? What is the risk of concussion? Using these monitors as research instruments is very important. In addition, knowing whether or not a concussion occurred is important in gathering that surveillance data. And currently, right now, with a culture of underreporting, we're challenged by knowing whether or not at a particular level of acceleration an injury has actually occurred or not. So we need that surveillance data with objective metrics that say an injury has occurred or not, in this case a concussion, in order to create these risk curves. If you take a look at this risk curve, you'll note that there are two flat horizontal areas on the risk curve. In those flat horizontal areas, reducing a biomechanical parameter like acceleration by 20% will not really dramatically change your risk of concussion. And there's an exciting, very steep area where reducing the biomechanical parameter, if it's acceleration in a particular direction, does have potential for greatly reducing the risk. Parents, athletes, coaches, and manufacturers use these risk curves to make informed decisions. These curves will change with age of the child, the direction that the head moves, and whether there's a history of traumatic brain injury or concussion. The committee found little evidence that was available to create these curves for youth. So the committee made 3 recommendations that will provide that much needed information. First, the surveillance that you just heard about. Second, you'll hear in a moment about the importance of objective metrics, whether or not a concussion has occurred or not, and injury threshold research that's specifically for concussions in youth.
Thank you. Art?
So while we have a definition of concussion that implicates pathophysiological processes and biomechanics, we still diagnose concussions based on observable signs and self-reported symptoms because there is not yet any evidence of what the biomarker would be, and that's a significant area of need. To try to deal with that in the current setting, it's clear in the research that people use multiple approaches to concussion diagnosis, and we think that's a good thing, although, again, without actually knowing what the biomechanical and biological markers are, it's difficult. But a multimodal assessment, including neurocognition, balance, and symptoms, seems to be a reasonable approach and is encouraged. Further, the evidence is pretty clear that while the brain is recovering from concussion, it's much more susceptible to secondary injury that could be worse, and in some cases lethal, although there's very little evidence, small numbers of cases of what's called second impact syndrome. So we still don't know a whole lot about that. But getting a second concussion while recovering from the first does appear to result in a more significant injury that takes longer to recover. So removal from play is an obvious common sense principle that we encourage and seems to show up in most of the newer state laws. While physical and mental rest is a common sense approach to managing concussions, there are not yet any controlled clinical trials for that or any other treatment for concussion. So this is an area that needs considerably more work. And while most people will recover without any sort of medical intervention, on the order of 90% will recover within 2 weeks, there is a 10 to 20% group that do not recover, and we don't know a whole lot about who those are. And in fact, in the literature, there continues to be kind of evidence that there's a small number of people within the larger group studies who have much worse outcomes, and trying to drill down into those individuals and discover what is unique about them is another area for further research. There's, as I said, there's little empirical evidence for the psychosocial treatments, so one of our important recommendations is that we start to look at clinical trials for what does work and what doesn't work. And recommendation number 2 is that the National Institutes of Health and the Department of Defense should support research first to establish objective, sensitive, and specific metrics and markers of concussion diagnosis, prognosis, and recovery in youth. And secondly, that this research should inform the creation of age-specific evidence-based guidelines for the management of short and long-term sequelae of concussion in youth. In terms of short and long-term consequence of concussion, the evidence is that people who have a number of concussions are more susceptible to another concussion of more serious outcome. So the more you get, the worse it is. And so keeping those numbers low seems to be an important concept to keep in mind. The length of time between concussions is also probably a critical factor that is not well studied at this point. There is no data to evaluate the relationship between concussion and risk of suicide and depression in young athletes. We need more data to determine whether repetitive head impacts and multiple concussions sustained in youth increases the risk for later conditions such as chronic traumatic encephalopathy and or Alzheimer's disease. We just don't have the connection from youth concussion to, say, older athletes yet. So we further recommend that the National Institutes of Health and the Department of Defense should conduct controlled, longitudinal, and large-scale studies to assess short and long-term cognitive, emotional, behavioral, neurobiological, and neuropathological consequences of concussion and repetitive head impacts over the lifespan.
Thank you, Art. Fred?
There's some evidence that enforcement of rules and fair policies contribute to reductions in injuries, including concussions. For example, there's some data from Canada where the age at which body checking was allowed changed, and as a result, there was a change in the incidence of concussions. Similar research needs to be done in a variety of other sports. Just as there's a pitch count in baseball, there's also been suggestion that there should be a hit count in sports such as football. However, while fewer head impacts are clearly better than having more, the threshold at which the number of hit counts should not be exceeded is really clinically unknown. So this leads to leads to our next recommendation, which is that The NCAA, in conjunction with youth sports organizations, should undertake an evaluation of rules and regulations governing sports and really look at the effectiveness of these rules on the risk of concussion. Likewise, the Department of Defense should undertake a look at their rules and regulations governing both training as well as sports played in the military academies, including combative training, to examine how those rules and regulations affect the risk of concussions.
Thank you. Christine.
Keeping with the theme of prevention, the committee was charged with examining the role of protective equipment in preventing concussion. The committee found little evidence that current helmet designs reduce concussion risk in young athletes and found no evidence that mouth guards or facial protections such as face shields in hockey reduce concussion risk. The genesis of this finding lies in the biomechanics concepts that were discussed earlier. What the literature tells us is that diffuse brain injuries like concussion are caused by a combination of linear and rotational forces. What we do know is that helmets reduce that linear portion. There's limited evidence that they can manage the rotational components of the impacts. This is in part due to standards. Helmet test standards were initially designed to evaluate a helmet's ability to protect against skull fracture and more serious brain injuries, and they do an excellent job of doing that. What we don't know, what the standards don't do right now, is evaluate a helmet's ability to protect against the rotational components of that impact. And therefore, the helmet standards do not comprehensively evaluate a helmet's ability to prevent concussion. But the most important concept of this section of the report goes back to the injury thresholds and injury risk curves that Dr. Margulies presented. Until those quantitative relationships are defined, which relate the engineering measures of linear and rotational acceleration to concussion risk, we don't have the data upon which to evaluate a given design's ability to prevent concussion. And this has led to our fifth recommendation, which is that the National Institutes of Health and the Department of Defense should fund research on age and sex-related biomechanical determinants of injury risk for concussion in youth, including how those injury thresholds are modified by the number and time interval between head impacts and concussion. Simply until we have this fundamental data, we cannot determine whether a given design of a protective equipment can mitigate concussion risk or not.
Which brings us, excuse me, to the sixth and final recommendation, which has to do with culture change, which is also a portion of the title of the report. I beg your pardon. As the committee had its conversations over the 6 to 9 month period, we returned many times to a discussion of personal experience and what we were finding in the literature about the way that this particular type of injury is viewed by athletes, by coaches, by parents, by administrators of sports. And even though, as Tracy said, there's an indication of increased willingness to report the experience of a concussion, there's still the sense that within many cultures, athletic cultures, there is the desire not to report on the part of the athlete. No, thanks, I've got some here. It's just not working. On the part of the athlete, not to report it because they feel like they're letting their teammates down. On the part of the coaches because it upsets the team that they have on the field, or their own belief that, you know, I had these, I'm okay, you know, this is just part of the sport. On the part of the parents who want to see their children excel and be accepted. There's this very subtle pressure that somehow, because this disease, because this injury is not visible, it's treated differently than an ACL tear. You know, if an athlete on the field tears their ligament, you know, you immediately get them off the field, you start treating them, you have rehabilitation. Nobody expects you to just wrap it and put them back in. But in some cases, that's what happens with concussion. We need to change that culture. And indeed, of the committee's recommendations, this is the recommendation that can go into effect for earliest. This is the recommendation that can happen first, with people saying, you know, that is an injury, we're going to treat it seriously. And so our recommendation number 6 is that the NCAA and the National Federation of State High School Associations, in conjunction with the CDC and Health Resources and Services Administration, National Athletic Trainers Association, and the Department of Education, all together should develop and implement effective large-scale efforts to increase the knowledge about what a concussion actually is and change the culture of how concussions are viewed by all of the participants in sports, coaches, and parents, so that when a child in this age range suffers a concussion, people say, that's a significant event, we're going to take care of you, you're not going to go back to competition, you're not going to go back to school until we're sure that you have recovered. So that is the quick background of the report, the rationale behind each of our 6 recommendations, and for the remainder of the hour, we are open to any of the questions that any of you might have in the audience. Again, please go to the microphones. I'll try to recognize you one by one. As the committee is aware, my undergraduate work was in a Quaker college, and I find silence really very comfortable. But that doesn't always work for everyone, so I think, Jennifer, you've had a couple of questions that have been kicking around for a while, so why don't you start us off?
Yeah, I'll just kind of get the conversation started again. I'm with the Institute of Medicine News Office. The report calls for several recommendations for more research, as you guys laid out in your presentation. Can you talk a little bit more about what we do know about concussions?
Thanks. Fred, Art, one of you want to start?
Well, I think I mentioned some of them. One, we know that, first of all, concussion is a biological process. It is a head injury. It's a mild injury in and of itself, but it has very significant consequences if not treated appropriately. And that sometimes, I think, is part of the problem with the cultural aspects of it, because by itself, 90% of people recover without any intervention, but if it's not dealt with appropriately within those 2 weeks, there could be some very significant consequences to it. So we know that, and we know that getting that second concussion is potentially lethal and definitely causes more serious consequences. We know that more is not better. We know that what we don't know is what the timing should be, but that when you start to accumulate a number of concussions, the risk of another concussion and a more serious concussion starts to go up. So more is not better in this realm.
Fred, any additional comments? Okay. Yes, sir. Please,
Tom
again.
Here with the Data Center for Sports Injury Research and Prevention. One of the things I was surprised to see missing from at least the summary report was a recommendation on how to evaluate or assess concussion in youth athletes. I'm talking younger than high school. For example, we're just in the process of finishing up the second year of a 2-year planned study in about 2,000 youth football players, where we're able to provide athletic trainers to 12 different communities in 6 different states around the country. And we contracted a qualitative researcher to debrief the athletic trainers that were working with the youth following the first year of the study. And the common theme from that assessment was that the athletic trainers had no idea how to assess concussion in a 5-year-old or a 7-year-old up to 14-year-old. Because if you ask a 5-year-old, do you feel nauseous, which is one of the common symptoms we often ask, you know, their parents may call it a bellyache, or they may call it vomit or other things. So the challenge for these athletic trainers, and I'm an athletic trainer myself, was that they just didn't know how to ask appropriate questions to the youth. And it's rare that you have athletic trainers working with a young population like that. But even up through middle school or high school, that may be an issue where the ability to assess concussion effectively may be challenged.
Okay.
I don't know if the committee had any thoughts on that.
Thank you. Tracy, you want to start?
Thank you. So I am also an athletic trainer, so I understand what those athletic trainers are going through when they're trying to figure out how a 5-year-old has a concussion when we're used to working with collegiate or high school athletes. In our second recommendation, we did indicate that the National Institute of Health and the Department of Defense should support research to establish objective, sensitive, and specific metrics to pretty much diagnose a concussion and look at recovery in youth. And then the second part to that was to have these two institutions look at the creation of age-specific, evidence-based guidelines for the management of short and long-term concussion in youth. So in that recommendation, we constituted youth as all the way down to 5 years old, all the way through the spectrum up to 21 years old. So in that actual specific recommendation, we are recommending that NIH and Department of Defense actually look at examining how we diagnose a concussion in youth athletes and how do we monitor them and how do we follow their recovery. And that would include, hopefully, developing some age-related assessment tools so that we can have a better understanding of what exactly is it that we're supposed to be asking these 5, 6, 7, 8-year-olds. What exactly is it that they understand? You know, I work with high school athletes, and one of the symptoms is fatigue, and some of the high school athletes don't know what that is. So when you ask a 5-year-old, they don't know what that is. So we need to develop these tools that are geared towards the younger population.
Art?
Well, you highlight what we didn't find because there's no evidence, and so we're kind of waiting on your study. We would love to have seen it, and that's a significant problem. We do, in the report, go through the tools that are available, and there are a couple of tools for younger kids that seem to have some good psychometric properties and things, but constantly we came to this place where we had to say, there's just nothing about kids. It's really a huge gap in the knowledge, and I think we felt consistently that this has to hit home. We have to start doing better studies for the younger kids. So appreciate your work in this and looking forward to the study.
Fred?
I think it's really a very important comment is that there's essentially nothing known about concussions in elementary school and middle school age kids. And that's really why there's a need for more research in this area. It probably makes sense to everyone in the room that guidelines for college kids don't apply to 5-year-olds. That's why we need the research.
Okay, thank you. Other questions or comments?
We actually have a question from the web. They ask, how would you measure a successful concussion management program in a school?
Art?
Well, we don't know how to do that. A couple of things are out there now, and we just concluded one study that's not yet published, so the committee really couldn't review it. But since we don't know what a concussion really is, it's hard to know when it isn't and what recovery is. But sort of the way I think most people are thinking about it now is number of second concussions that occur, especially within the first month or two, is a suggestion that maybe they really weren't recovered. But it's a very difficult, I mean, we're really more into sort of system of care issues, and there's absolutely no published study that we could find that talked about large-scale programs. And in fact, one of the things that I noticed in the literature is that there's more research related to, targeted studies and doctor visits, emergency room kinds of things, and some of these larger scale programs in high schools really haven't been looked at for their effectiveness, and they really need to be. So again, it's a huge gap in the literature that needs to be addressed.
I guess I might add to that. Go ahead if you're ready to go to the microphone. the question kind of takes us in a direction that I think is very consistent with the first recommendation, is a lot of what's in the literature right now is numerator. Incidence in this population, this study. We don't really have what we need in terms of denominators. So one of my criteria for a successful program in a high school or any other type of institution is the fact that somebody in that institution is starting to think about the whole population and starting to have a mechanism whereby they can do an assessment of where that population is at a given start point, what they encountered, what the incidence is of injury, how they recover, what the incidence is of seconds. So I think the question sort of goes towards how do you start thinking about managing and identifying this on a population basis, and that would be an element of a successful program to me. On that microphone, I don't know whether you have a question or comment on that last one.
A question, just a bigger picture question for parents
If you
who
could
are,
identify yourself.
Oh, I'm
and-
sorry,
Yeah.
Beth Parker from Channel 5 News here in DC. For parents who are trying to digest all of this, can you give sort of, in a nutshell, some advice, having looked at all the research that's out there? What would you say to parents?
I will defer to the parents on the panel. Fred?
It's a very good question. I think what we can say is that concussions are a potentially serious injury, have potentially serious consequences, that encourage your child to tell you if you have symptoms. If the child has symptoms after getting hit in a game, they need to tell the parent, they need to tell the coach, they need to sit out. That the parent should realize they should take the child to a qualified healthcare provider who understands concussions and can make good recommendations about what kind of care, what kind of length of time to stay out of play, how to return to school.
Tracy?
I also think it's very important for parents, school administrators, athletic departments to also be educated on the signs and symptoms of a concussion and the serious consequences that can result if an athlete continues to participate. So I think one of the things that parents can do is not only be supportive when their child has a concussion, but also learn about what a concussion is and learn about what are the warning signs of a concussion, so that they are able to recognize, if their child doesn't realize that they have a concussion, then the parent can recognize that they may possibly have a concussion and then go to a healthcare provider to make sure that the child is okay.
Christy and then Art.
I think another thing parents can do is to make it their responsibility to understand the coaches and leagues of the activities that their children are participating in. Make sure those leagues have a return to play protocol and follow it. Make sure that those coaches and leagues have that education that Tracy just spoke about. It can be the parents' responsibility to ensure that those that are surrounding their children are as educated as they can be.
Art?
Because so many concussions resolve without any direct intervention, parents often think, well, then we don't need to do anything, and that might not be the right message. There isn't a lot of evidence yet, but paying attention to your child for, are they different? Are they acting different? And checking in with schools and teachers. Do they seem different in the classroom? Can be really important. There really isn't any way to know what to do, but in some ways it might be more important what not to do and what kinds of things you can engage your child in when they are recovering that don't make things worse. And so paying attention to, if they're staying up late at night studying and not feeling any better, that's probably not a good thing to be doing, and getting support for the schools. And we find that the schools are becoming more and more supportive of managing and monitoring and reducing workload, but that's an ongoing challenge, is to get them on board. So getting to your schools and to recognize that the concussion itself has potential serious consequences, and just like pushing through in sport, pushing through in academics can potentially be just as problematic, and maybe more problematic. Again, the data's not there, so we couldn't really comment on it, but it's that common sense principle based on the things that we do know. So I always tell parents, pay attention. It's really important to pay attention to your kids.
I guess the only thing I would add to that goes back to our culture recommendation, parents need to be sensitive to what the culture appears to be of the team or the sport that their child is participating in. And if they get the sense that that particular coach is not sensitive to these issues, is asking the child to do something that may not be comfortable for the child or may look like they're trying to overlook that, the parent needs to say, no, that's not acceptable. I know this is serious, and I want a different reaction.
Just want to add one little piece to that we haven't brought up today about culture, and that is the peer culture. So it's not just between the parents and the child's perhaps resistance to report their changed status and feelings, but there's also an aspect of peer pressure. And that culture can be addressed now. We don't really need to wait for that. So that can come from the parents, that can come from the coaches, but that can come from the athletes themselves.
Other comments or questions?
We have another question from the web.
I'm glad the web people are really active this morning.
They are. Actually, we have a number of questions. Again, this is about culture. Are we looking at a trajectory of culture change similar to the ones of heart disease in the 1950s? That is, it will be shown to depend so much on lifestyle choices.
If the questioner was present, I would ask them to say a little bit more about that. Certainly what we went through with heart disease is the understanding of prevention and different types of behavior, different types of lifestyle choices. So if that's what they're getting at, I think we are talking in the cultural recommendation changes in attitudes not only in the part of the participant, the youth themselves, and making different choices, whether it has to do with the style of play, the types of sports that they choose to play, how they protect themselves as they participate, but also the understanding, as Susan pointed out, that they have with their peers. What are we as a team? How do we look out for each other? Other thoughts on the panel that I may be missing there? Art?
I think it's important to recognize that we're not saying that we should stop playing sports, that we need active lifestyles, and what we want to do is make it safer. So any changes in lifestyle should not include reducing the amount of physical activity kids get.
Good. There are definitely risks for sedentary lifestyle, and that was true with heart disease too.
We have another web question. Is there research that evaluates how well coaches are following the return to play guidelines after a child has a head injury? And also, are there interventions that physicians may be able to provide to them?
Fred?
The answer is no. There really has not been research to date published on how well coaches are following the return to play guidelines. There are laws now in nearly all states governing this, but the evaluation of that has not happened.
I thought you were going to get up. Captain, to the microphone.
Thank you. Good morning, Rita Shapiro, and I'm from Defense Center of Excellence. I have a question built on the comment that was brought up about coaches and, we're all talking research, but while the research is undergoing, is there a thought, did the committee think about how to educate, in culture change? Yes, we talked about students and the, children, but parents. But what about coaches and the trainers and the perception of sport that, yes, bigger, more impact is better? That seems to be quite prevalent lately. Did committee think anything about that? Or like a national level campaigns on injury prevention and skills building rather than impact?
Okay, thank you. Tracy, you want to start?
I think the culture change for coaches needs to continue to occur when we talk about sports-related concussion. So when we think about 10, 15 years ago, there was a culture in heat illness where we restricted athletes from getting water. And if you did well at practice, you're allowed to drink water. Well, then people were dying of heat strokes, so we changed the culture and now allow those individuals to get water whenever they can. I think we need to have that same type of a change for the culture for coaches. I know that I do work with coaches, and some of them are fantastic when it comes to sport-related concussion, but I can also tell you there are still coaches that are out there that believe exactly what you said, that bigger, faster, stronger, and don't be a wimp, get out there and play. And I think what we can continue to do is educate the coaches on the signs and symptoms of concussions, but also explain to them that concussion is a brain injury. You only have one brain, and you need to be careful with it. You cannot be allowing a child to hide their symptoms as a coach and not tell a healthcare provider and not tell the athletic trainers or tell a physician. So I think with more education, we need to change the culture of what and how coaches feel about concussions. So I think we've made some changes. I don't think we're there yet. So exactly what you said, I still think there are coaches that would rather hide that athlete to continue them to allow them to play because they want to win at all costs.
Got Susan and then Christy.
From our review of the literature and through our 2 public sessions, it was clear that the effectiveness of education was not really being assessed. There are a number of things that are being tried, but it was clear from our public sessions and our reading that sometimes it was implemented in a very cursory manner. The educational component might be something that was handed out without actually ensuring that there was any learning that was going on there, as well as not actually reinforcing it later in the season. So it's not enough to check the box. What we're talking about is effective educational methods to change the culture. And it wasn't for the committee to evaluate which methods might be most effective, but we actually recommend that those who are at this interface should be evaluating whether their methods are effective, and if not, try it something else, another method.
Christy?
I think the number of questions around this issue illustrate how complex it is. And I think whenever we're thinking about how to change behavior, there's social science theory that goes from education to knowledge to behavior. And the science that recommendation 6 speaks to needs to make those connections across a diverse set of actors, parents, coaches, teachers, athletic directors. And so those links need to be studied and evaluated to make sure we go from education to actually changing behavior, which is the goal we're trying to reach.
Yes, sir.
Hi, I'm Chris Gorski from Inside Science News Service. I know in the report you talk about the rules and the sort of age-based rules, such as body checking in hockey and those kind of things. I was wondering if there were any more specifics from other sports you could talk about that seem to be good interventions to reduce risk.
Fred?
I don't think we found any other studies that have really looked at the effect of rule changes. And I think that was really the point of the recommendation, was that there probably have been rule changes that are effective, but those need to be analyzed and looked at so we can really tell which are the rules that make a difference.
Other questions? Here comes the web again.
Yep, we have another one from the web. The concussion rate for high school football players is nearly twice that of college football players, according to the study. Any thought of why high school players are more vulnerable?
Tracy?
Well, right now we have found that there is a higher incident of concussion at the younger age, at the high school level, and that possibly could be due to the development of their brain. In that age population is more vulnerable to concussion. They also, what the committee has found is that the younger the athlete, at least at the high school age, we don't know anything below the high school age, but the high school age athlete tends to take longer to recover from their concussion.
Fred?
The other thing which we don't really know is what's the reporting bias. Are high school kids more likely to report their concussions than are college kids? Similarly, the data seem to indicate that there are more concussions in girls than in boys, but again, we don't know if there's a reporting bias there as well.
Art?
So this isn't in the realm of empirical science, but in the schools I work with, I am finding that the high school trainers are erring on the side of caution. They've sort of gotten the message, and so there could be some over-identification going on as well, just to be safe, because it is difficult to know, and so often they will decide to treat it as if, because they're not sure, but they'd much rather be cautious and conservative than to say, no, you're okay, and go back to play. So it might be that the education is paying off, but I have noticed this trend, and yet there is no real firm evidence on this yet.
And Susan?
I think there could also be a parental factor. The high school students are in the home setting. The college students are not in the home setting. So in terms of someone else making observations and helping the athlete seek attention, that may play a role. But it does bring us to our second recommendation, which is that we need some metrics that are objective metrics that you can be used in children over a variety of ages to detect whether or not a concussion has occurred, because without that, we're reduced to just having a self-reporting or more subjective metrics that depend on the athlete's willingness to participate and at their best effort.
All right, we're at 2 minutes until the hour, and Jennifer, I think you wanted to close things out. So on behalf of the committee and Dr. Rivara, the vice chair, I would like to thank all of you for your interest and participation this morning. For all of you on the web, thank you also for tuning in. I hope you find some of this to be helpful. For those of you here who are very shy and didn't want to ask questions, the committee will be around after we break in case there's some one-on-one discussion you'd like to do. Jennifer, back to you.
I'm just going to ask one more question that we received from a reporter from Neurology Today, Kurt Sampson. He asked, there seems to be a lot of clinics advertising for walk-in baseline concussion testing for kids. How valuable or appropriate is this given the lack of data, and what are they measuring exactly at these clinics?
Okay, my experience is the question you get asked when you think you're done with a hearing is the most dangerous one. So whoever would like to respond to that.
Well, he's correct. The evidence is mixed on this, and so we have studies that show that using baseline testing is effective for identification of concussion, and then there are studies that show that it's not, that you don't need the baseline in order to use a neuropsych test. You can just use normative standards. So I think the answer is still not in. They are expensive, costly, difficult to do. But from a sort of common sense clinical research perspective, you always want a baseline to compare to. So particularly when you're dealing with children who are not typical, who have learning disabilities, ADHD, other conditions that might make their baseline not be in the strictly average range. So you get more specialized information on individuals. So that there are arguments that go both ways. I can't say that we have a firm answer on this question, and if a program decided not to use it, I don't think they could be criticized for going against the science, because the science is not settled yet.
Okay. Do you want me to close it off, or did you want to do anything more? Okay. I am now in the position to say thank you very much. We're done for the second time. But we will be around if you have any individual questions.